All right, y'all, let's do a little bit of cardiac tutoring. So, key points to know. Each and every um, diuretic pretty much puts us at risk for dehydration. So, things that we want to look out for with that is going to be our dry mouth, increase in thirst, weight loss, weight loss, weight loss, weight loss. Remember, the biggest indicator of fluid gained or lost is weight. So that's going to be priority for dehydration. Nursing actions, we want to monitor the electrolytes because when we're dehydrated, our sodium goes off the chain, our potassium can go off the chain, everything. And then we want to make sure that we're at least putting out 30 mLs an hour. Anything less than that is problematic. Okay. Furosemide can cause ototoxicity. So the signs that we're going to look for with that is going to be that hearing loss, tinnitus, dizziness, headache, vertigo. I can't ever spell that, but vertigo is going to be another sign that we need to look at. Biggest thing with this is going to be avoid use with other ototoxic medications. Typically our NSAIDs, like our aspirin or our aminoglycosides, our NATs, gentamicin, neomycin, acinomycin, tobramycin, streptomycin. So we're really worried about those. Hypotension or orthostatic hypotension, also known as posterior hypotension. That's going to cause some lightheadedness and dizziness. So our biggest issue there is fall precautions, and we want them to change positions very slowly. Of course, monitor the blood pressure and all of that. As far as our electrolytes, especially with some of our blood pressure meds, but a lot of our diuretics, we're worried about hypo or hyperkalemia. So hypokalemia is a potassium that is less than 3.5. We can have nausea, vomiting, fatigue, leg cramps, and generalized weakness. Our big thing, remember, potassium always affects the heart. So we want to slap them on a cardiac monitor and monitor that cardiac status and monitor the potassium levels. We want to make sure that they consume foods high in potassium, such as bananas, potatoes, fruits, nuts, citrus fruits, things like that. Hyperkalemia can happen with our potassium sparing diuretics like spironolactone. We have weakness, fatigue, dyspnea, and dysrhythmias. So, of course, we want to restrict the potassium in the diet. Salt substitutes. So, a lot of people who have hypertension may use salt substitutes to be a part of that DASH diet, the heart healthy diet. No salt substitutes. Those are filled with potassium. And then, of course, do not mix with medications that increase potassium. So, like our ACE inhibitors can increase potassium. So, we want to make sure that we're not putting two things together that are going to make it even higher. Angioedema, that's skin wheals, swelling of the tongue, and pharynx and larynx. This is like the first sign of anaphylactic shock. So we want to make sure that we're reporting this. And of course, we're going to treat with epinephrine, and they cannot have that medication. Okay. So let's start with our diuretics. We have our furosemide. This is also known as Lasix as the brand name. You won't be tested on Lasix, but if you can match the name up in your head. Of course, we're worried about dehydration. We're worried about hyponatremia with the dehydration. We're worried about hypotension and ototoxicity and hypokalemia. All of these are potassium potassium depleting except for our spironolactone. Okay. So we're going to have hypokalemia. So we're going to follow all those things we just talked about. And this is the only diuretic safe for renal impairment. So if we have somebody who needs a diuretic and their kidneys aren't doing great, this is the only diuretic we can give. Okay? Thiazide diuretics, this is our hydrochlorothiazide. They're all going to end in thiazide. Again, dehydration, hypokalemia, hyponatremia, hyperglycemia. So we got to be careful with our diabetics. And hyperuricemia, we got to be careful with our gout patients. So now we have our potassium sparing diuretics, our spironolactone. These ones end in actone. Another one that may pop up, and it does the same thing, is EPLE R E N O N E. I'm going to respell that out loud. EPLERENONE, eplerenone. So this is another one, does the exact same thing. So we have things like hyperkalemia. So remember, because it's potassium sparing, we risk high potassium. And it can also have endocrine effects. Those endocrine effects can include gynecomastia, decreased libido, things like that. And then we have mannitol. Mannitol is a very, very, very different diuretic. So we don't want it to be put in these categories. Okay, so it's very different. How these other diuretics work is it pulls the fluid out of the body and we excrete it through our urine. How mannitol is going to work is it's going to be used to treat things like increased intracranial pressure and increased intraocular pressure. So what it's going to do for increased cranial pressure, that means too much fluid on the brain. For increased ocular pressure, it means too much fluid on the eyes. So what this is going to do is it's going to pull the fluid out of the head or out of the eyes and move it into the rest of the body. So when that's happening, we're worried about heart failure, pulmonary edema, crackles, things like that, because it's putting our body into fluid volume overload, because that water, that fluid that's being pulled is not going straight out of the body. It's going into the body to then be filtered out. So we worry about those things. Of course, we're worried about fluid electrolyte imbalances, metabolic acidosis, things like that. Okay. So now we have some blood pressure medications. So the first one we're going to talk about is our ACE inhibitors. They end in pril. So anything it ends in pril, you need to know that it is an ACE inhibitor. We get that first dose orthostatic hypotension. So what does that mean? That means that when we give it for the first time, we have a risk of their blood pressure dropping super, super low. So if we're at risk for that, we want to make sure that they get taken off temporarily of other things that may drop their blood pressure, and then we can slowly bring it back in, okay? We want to do, of course, we're going to have, we talked about the ones being the ACEs. So ACE inhibitors, your side effects are ACE, angioedema, which we got right here, cough, which we got right here, and elevated potassium, which we got right here. Okay. Remember, we can also have with captopril only, we can have neutropenia. We got to remember that's specific to captopril. Okay. Some other things to remember with this is that cough is not normal. Cough is going to be an early sign of issues, so we want to make sure that we are reporting that and they need to be taken off of it. This is also tetragenic, so no pregnancy. Okay. Very similar to ACE inhibitors is our ARBs. So these medications are going to lower blood pressure as well, and they all end in sartan. So our complications include angioedema, hypotension, dizziness, and lightheadedness. This one does not cause cough or elevated potassium. Now, it is important to remember that most likely if you have if you have an allergic reaction, a cough or angioedema to a prill, you will probably have it to a sartan. And if you have angioedema with a sartan, you'll probably have it with a prill. So we want to, if you're allergic to one, you're probably allergic to the other. Okay. These are also tetragenic as well. We also have our direct renin inhibitors, aliskiren, and that is going to be very similar to an ACE inhibitor. Very, very, very similar. It can cause cough and angioedema. It can cause rash. It can cause high potassium. It can cause diarrhea. So very, very similar to our pros as far as our side effects go. Okay. Next, we have our calcium channel blockers. These are our very nice drugs. These can be used in heart failure as well as blood pressure. So very nice drugs are verapamil, nifedipine, and ditalizam. There are a few others in this group but the rest of them end in dipine, just like nifedipine. Amlodipine is another one, but it ends in dipine. So some complications from this is a reflex tachycardia. So normally these medications are going to lower our heart rate, but as a side effect, it can cause that reflex tachycardia, meaning it instead causes tachycardia. So for that, if we do get reflex tachycardia, we add a beta blocker, which we'll talk about here in a minute. Other things, of course, are orthostatic hypotension. We can get peripheral edema. We do want to report any kind of peripheral edema, so that's going to be edema within our arms and legs. We may need to give a diuretic for that, or we can be flooding the body with too much fluid and go into fluid volume overload. It does suppress the cardiac function, which is why it should be dropping our heart rate and dropping our blood pressure. This is to take some of the workload off the heart, which is why it also works in heart failure. We do want to withhold the medication for a heart rate less than 50. So now we're going to have our alpha androgenic blockers. These are going to end in zosyn, prazosin, doxazosin. These medications, we can get that first dose orthostatic hypotension. We can also get to reflex tachycardia, which we already talked about, and headache and dizziness. For our centrally acting, which is our clonidine, it can cause dry mouth, which things like that, we want to just make sure we're encouraging frequent water and making sure that they suck on hard candies, things like that. Big piece for this is the rebound hypertension if stopped abruptly. That can lead to a hypertensive crisis, which can kill you. We are never going to abruptly discontinue. It's always going to be a slow taper. Okay. So then we have our beta blockers, especially our beta 1 blockers. We have, they end in OLOL. We have metoprolol or propranolol. So our issues with this could be bradycardia, decrease the cardiac output. This could be a side effect because it can make it worse, especially if we're using it for hypertension. But it can also help with heart failure. And then once again, it decreases that cardiac output by decreasing the workload of the heart. It can cause bronchospasms, especially with our non-selective, where it does block 2 as well, which is our propranolol. So we will not give this medication to people with lung issues like COPD, asthma, things like that. That being said, even if the person does not have a pre-existing lung condition, we still want to monitor the lungs because they can get bronchospasms even without a pre-existing condition. And once again, we're going to withhold for less than 50. Our other one that we're going to look at is our nitroprusside. This is going to be used to treat a hypertensive crisis. This is only going to be given in emergency situations in the hospital through the IV. We can, of course, accidentally lower the blood pressure too much and get excessive hypotension. So we got to be mindful of that. We can get cyanide poisoning from this, which is going to look like headache and drowsiness. So this is one of those times, headache and drowsiness is a huge sign. We're worried about that. Bradycardia, and we can get tachycardia as well. It just depends on what the body's doing. So we really need to monitor for those ECG changes. All right, so some meds for heart failure. We have cardiac glycosides. This is our digoxin. So for this medication, we are going to have complications of dysrhythmias and cardiotoxicity, which includes hypokalemia. Hypokalemia can exacerbate toxicity. So we can have things like GI effects and CNS effects. So toxicity includes anorexia, especially, and nausea and vomiting, especially as a first line, and visual changes, such as halos, dizziness, things like that. We want to withhold the medication for a heart rate 60 or lower than 60, I should say. And remember, this does not cause ototoxicity. All right. So then we have our inotropic sympathomimetics. Remember, we watched a video on this in class. This is our dobutamine. So our complications can be tachycardia, cardiac dysrhythmias, and angina pain. So remember, the goal of this is actually going to be to speed up the heart because of the heart failure suppressing the heart. This is kind of going to jumpstart our heart per se. Of course, this is only going to be given IV and will help get someone out of a dysrhythmia and out of heart failure. Another antidysrhythmic medication that you may need to know is going to be a potassium channel blocker, which is amiodarone. Some complications of this medication can include pulmonary toxicity. That includes pneumonitis. So with that, that's going to be a fever, cough, shortness of breath. So we want to make sure we're mindful about that. It can also cause dizziness, fatigue, malaise, as well as ataxia and paresthesia, which is that numbness of the hands and feet. And it can also cause bradycardia and hypotension. So these are some things we need to look out with this. And then we have our angina medications. So this is going to be nitroglycerin, organic nitrates. I also need you to be able to recognize isosorbide as a nitrate as well. Okay. So some complications we can get from this is headache, orthostatic hypotension, reflex tachycardia, and a tolerance. And it cannot be taken with sildenafil. Remember, that's our Viagra. With the headache, that is normal and it goes away after a while. So that is not that's a teaching that we'll just need to say like it should subside and they can take acetaminophen to help it. This medication can be given to treat an acute angina attack, meaning that chest pain comes on, you stop what you're doing, and you put a fast-acting nitrate in your mouth or however you take it, and it should stop the pain. If you are if you take it and it doesn't go away, you need to take another one and call 911. We can also have long-acting to treat that chronic angina. So this is our patches or our ointment, and it stays on for most of the day, and it helps prevent an angina attack from coming on. Some things that ATI likes to trick you with is that you will not use a patch or ointment to treat active angina. It's to prevent it from happening in the first place. If somebody has a patch on and they have an active angina attack, they can take a sublingual rapid acting and call 911. And now we have our anti-lipidemics. So these medications are going to help reduce our triglycerides, our HDL, increase our HDL and decrease our LDL. So these treat hyperlipidemia, which is too much fat in the arteries. So our first one and our most common is going to be our reductase inhibitors, which are known as statins. So atorvastatin, simvastatin, lovastatin, any of them that end in statin. Big things with this is they can cause hepatotoxicity, myopathy, and you know grapefruit juice. So of course with our hepatotoxicity, we are going to report things like jaundice, nausea, vomiting, abdominal pain, abdominal distension, and dark urine or clay or light colored stools. For the myopathy, we are worried about that muscle breakdown. So we're going to monitor CK levels, and we want to report any kind of muscle pain or weakness because this can lead to rhabdomyolysis. Next, we have our bile acid sequestrants, colcicillin. The main complication of this one's going to be constipation. And then we have our fibrates, which is gemfibrozil. These medications are going to cause gallstones, myopathy, and liver toxicity. So the same things we want to report for statins, we want to report for gemfibrozil. And with the gallstones, we need to make sure that we are reporting any kind of gallbladder issues, such as an inability to have fried foods or upper abdominal discomfort and bloating. So things like that, we need to make sure we're doing. We're going to take these at bedtime or in the evening because our lipids are synthesized usually the most in the evening. Big thing is a lot of these are tetragenic. One thing I want to touch on because I think I forgot to say it earlier, back to our diuretics, furosemide is a sulfa drug. So if you have a client who is allergic to sulfa, they will probably be allergic to furosemide. All right.